My name is Carrera Moreno and I'm going to talk about the fallopian tubes. Their function. The fallopian tubes transport the ova from the ovary to the uterus each month for fertilization. In presence of sperm and fertilization, the fertilized egg will be transported by the fallopian tubes to the uterus for implantation. The structure of the fallopian tubes. The fallopian tubes are divided in 3 segments. The first segment is close to the uterus and is called isthmus. The second segment is the ampulla, the site of fertilization, and the last segment is the infundibulum, which gives the rise to the infimbrae, finger-like projections that are responsible for picking up the egg released by the ovary. The complications. Complications of fallopian tubes can be blockage of the tubes, ectopic pregnancies. Ectopic pregnancies are results from fertilized egg staying in the tube rather than traveling to the uterus. These pregnancies cannot be carried to term or converted into normal pregnancies and needs to be removed with surgery the fallopian tube that was affected. Here's a video about the fallopian tubes.
Fallopian tube recanalization and selective salpingography. The most common cause of infertility in women is a blockage or narrowing of one or both fallopian tubes. During fertilization, the egg travels from the ovary through the tube and into the endometrial cavity of the uterus. Conception cannot occur if a blockage prevents the egg from traveling its normal path through the fallopian tube and into the endometrial cavity. A non-surgical outpatient procedure called hysterosalpingography can be used to check for a blockage in the fallopian tubes. A catheter is placed through the vagina and into the endometrial cavity. Next, a dye visible under X-ray is injected into the endometrial cavity. If there is no blockage, the X-ray should show the dye flowing out of both fallopian tubes and into the surrounding space of the abdominal cavity. If one fallopian tube is blocked, the dye will not spill out into the abdominal cavity on that side of the patient. In some cases, blockage can occur in both fallopian tubes. Notice that the dye will remain within the endometrial cavity. When the blockage is confirmed, selective salpingography can be performed. The catheter is pushed into the os, or opening of the blocked tube. A thin guide wire is placed through the catheter, pushed directly through the blockage and out the opened end of the fallopian tube. A small microcatheter is then fed through the first catheter and over the guide wire out the fallopian tube. Dye is sent through the microcatheter. A new X-ray should show the dye flowing out the opened end of the fallopian tube. As the microcatheter is withdrawn, saline solution is pumped through it into the fallopian tube. The pressure of the saline solution will clear any remaining debris that caused the blockage to open. The patient can return home the day of the procedure and can go back to a normal routine within 24 hours. Little to no pain should be felt post-procedure. Now that the tube is opened, the egg can pass from the ovary to the endometrial cavity. Successful conception should now be a greater possibility.
Structure of the fallopian tubes. The fallopian tubes as in the video, the fallopian tube blockage. When fallopian tubes are blocked, They keep sperm from getting to the egg or block the passage of the fertilized egg into the uterus. Causes of fallopian tube damage or blockage can include pelvic inflammatory disease and infection due to chlamydia, gonorrhea, or the sexually transmitted infections, or ectopic pregnancy. Here's another video.
It is often caused by tubal disease and tubal blockage. In some cases, the tubes are blocked at the very end. In this case, the tubes are blocked at the very beginning. As a result, we take the patient to laparoscopy. We placed an incision at the umbilicus and placed a port, and then placed a laparoscope to evaluate the pelvis. There was absolutely no scar tissue at the end of the tube, but when we attempted to inject dye through the tubes were completely blocked, just as we had seen on the HSG. Hysteroscopy was then performed, and the beginnings of the tubes were visualized. You see here on the right side and then on the left side. We did not see obstruction at the beginning of the tube, but they were clearly blocked. We then placed a guide wire with a catheter overlying it through the beginning of the tube to relieve the obstruction. We placed it carefully, and we used the laparoscopy to guide the guide wire in order to avoid any possible injury or perforation to the fallopian tube. Here you can see the guide wire being passed up to about half the tube on the right side. It passes easily, the obstruction is relieved. At this point, the guide wire is then removed and dye is injected into that tube to confirm that the remainder of the tube is patent as it is. You can see the blue dye coming through. On the left side, the end of the tube isn't quite as easily seen, but nevertheless is identified. The guide wire and catheter is placed now on the left side, slowly and gently under laparoscopy guidance. And one can see the wire being passed approximately to a third of the fallopian tube. Here's the guide wire, and the obstruction is relieved. The guide wire is then removed, and selective chromoperturbation of that tube confirms that the tube is filling with dye and spilling, and the remainder of the tube is normal. You can see the fimbriated end spilling the blue dye. At this point, the catheter is removed, the hysteroscope is removed, dye is then injected through the cervix. Dye has to travel all the way through the uterus and then out through the tubes completely. And you can see dye coming out first on the right side as indicated here, and then on the left side. And as a result, the tubal occlusion has been removed.
As we saw in the video, this procedure is to see if there's any blockage in the fallopian tubes. Diseases. There are several diseases that can affect the tubes, interfere with their main function, that is to transport the fertilized egg to the uterus. Diseases can affect the fallopian tubes, often can cause infertility. Endometriosis, hydrosalpingitis, pelvic inflammatory disease. Here's a video about endometriosis.
Endometriosis is a condition where tissue, similar to the lining in your uterus, grows in other areas of your body. If you are a woman, your reproductive system includes the vagina, uterus, fallopian tubes, and ovaries. During a normal menstrual cycle, your ovaries make chemicals called hormones, which signal the lining of your uterus to thicken. The lining, called the endometrium, builds up to prepare to receive a fertilized egg. If the egg isn't fertilized, the uterus sheds the lining through your vagina. This monthly bleeding is called your menstrual period. If you have endometriosis, the lining-type tissue grows outside your uterus for reasons that aren't clear. The misplaced tissue responds to the hormones just like it would if it were inside your uterus. The tissue continues to thicken, then sheds and bleeds with every menstrual cycle. However, the blood and tissue that are shed outside the uterus have no way to leave your body. The trapped endometrial flow can irritate the surrounding area, causing inflammation and pain. Bands of scar tissue, called adhesions, may form, sticking one organ to another or causing your fallopian tubes to close. This can affect your fertility, which is the ability to become pregnant. Endometriosis can form endometriomas, also known as chocolate cysts. These cysts are fluid-filled sacs on your ovaries that can affect fertility. Endometriosis may also result in abnormal bleeding. The most common sites for endometriosis are the ovaries, fallopian tubes, the outside of your uterus, the supporting structures around your uterus, and the lining of your pelvis called the peritoneum. Other sites include your bladder, rectum, and intestines. If you have endometriosis, you may have one or more of these symptoms. Chronic, usually worsening central pelvic pain. Pain before or during your period. Pain during sex felt deep within your pelvis. Painful urination during your period. Painful bowel movements during your period. Abnormal bleeding. Diarrhea, constipation, or nausea. And difficulty getting pregnant, called infertility. Your doctor may recommend treatment options from the following categories. Pain management medications, such as aspirin, acetaminophen, or non-steroidal anti-inflammatory drugs, also known as NSAIDs, provide relief from pain. Hormone therapy, such as birth control pills, can prevent monthly endometrial buildup and bleeding. You may need a surgical procedure to treat the tissue causing pain or bleeding. Examples of such procedures include removal or destruction of endometrial tissue, removal of adhesions and scar tissue, removal or drainage of cysts, removal or destruction of nerve fibers that transmit pain, removal of your uterus, called a hysterectomy, or removal of your ovaries, called an oophorectomy.
Thank you.